Hi, everyone. Welcome. We'll start in about 5 minutes. The session is being recorded. You'll have a chance to get a recording at the end. There's also a poll. If you look at the bottom of your screen, there's a poll that you're willing to fill out if you'd like to contribute. Please feel free to use the chat when you have questions. About 3 more minutes. Just about another minute and we'll get started. Okay, I hope everybody's having a chance to join. We're about to get started. All right. I want to welcome everybody to a virtual visit for direct-to-consumer care, an expert panel hosted by Green Room Technologies and sponsored by Medley Med. Excuse me. So Medley Med Direct is our sponsor today, and they're a customizable solution for virtual care. They have components of consumer and patient engagement, telemedicine and practice management, online and retail pharmacy, including best sourcing and pricing on the back end, as well as a digital storefront. So you'll get the chance to learn more about them following the seminar. We will send out a link so that you can learn more and perhaps get a demo if you're interested. I'm Kristen Norton. I'm the Chief Executive Officer of Green Room Technology and the moderator of our session today. And Green Room is very interested in direct-to-consumer care and excited to have this panel on board with us today. Our panel includes a wide breadth of people across the direct-to-consumer care industry because it is such a wide industry. We have Dr. Robert Morgan, who is the CMO at Let's Get Checked. And he's here today to represent an industry expert and a leading success story in the field. They've been around for quite a while and have done very well. And he'll be able to talk to us about how it was to build this technology for themselves in order to be able to serve customers for online testing. We'll also have Sherry McLaughlin, who is an established provider and a movement specialist. And Sherry comes from a long background of providing care, but is fairly new to virtual care. So she's going to talk a little bit about what she does and how she feels like her patients will be benefited by being seen virtually, and what her hopes and challenges are in regards to technology being new, and how she might be able to use technology to get a leg up. We'll also have Dr. Lisa Fast. Lisa comes from the pharmacy world because, of course, direct-to-consumer care really is an overlap of telehealth and pharmacy in many cases. And she's going to be talking about not only how direct-to-consumer care companies can use pharmacy, but also how pharmacists, especially independent community pharmacists, might benefit from adding virtual care services to their current programs in order to keep their current base, keep them from going to the large box stores, expand their base via virtual care, and generate more revenue. And lastly, we'll have Sherry Dasho, who will participate throughout the event, talking to us about legal and regulatory aspects of direct-to-consumer care. But before we get started, I guess I should say a couple of housekeeping type things. So you are being recorded. The session is being recorded, and you will get a chance to see that later. There is a poll at the bottom if you'd like to fill that out. And if you have any questions, please just feel free to use the comments, and we'll do our best to monitor those. If we have time during each speaker, we'll ask a few, and if not, we'll ask at the end. And then you'll also have the opportunity at the end to get in touch with the speakers themselves if you have follow-on questions. So let's just start out with what is direct-to-consumer care. I think, again, it has a very broad topic, and it can range across really the traditional telehealth, as you might have known it, to what we call today direct-to-patient, direct-to-consumer, or perhaps direct-to-employer care. The HHS.gov recently came out with some pages on their site specific to this field. And you may have also read Dr. Bob Teague's blog recently that Green Room put out that talked about the fact that there's been a surge in telehealth, of course, during the COVID epidemic, but then it sort of faded away. But despite that, and despite the drop in stocks like Teladoc, direct-to-consumer care is still growing rapidly. And we'll be talking about different varieties. For instance, direct-to-consumer might be more wellness, things in which a provider, an MD, does not have to be involved, but they might in a more limited capacity. And then direct-to-patient really involves more of a provider that's prescribing medications. And then direct-to-employer, which Cheryl will be talking about, where she serves employer groups, giving them movement training for their employees directly. And so there's a different nuances to each of those, but they overlap in many ways. And then lastly, Lisa, as we said, will talk about how pharmacists can take advantage of this type of service as well. And because we're largely focused on technology on this piece, I wanted to kind of show you this article by Deloitte, who discussed how these consumer health brands today are now hosting their services in many ways. So some hosts allow you to do virtual health and e-prescribing. Others have a full platform that includes e-prescribing and pharmacy fulfillment delivered straight to your home. And those can be the back-end partners for these frontward consumer-facing brands. And then there are the fulfillment people. So you might have a company that just does the fulfillment while you're using the B2B elsewhere. And so, and given that, we'll start off with Dr. Rob Mordkin. And as I mentioned, Dr. Mordkin is with Let's Get Checked and has been with them for quite a few years and has seen them grow and change. So he's going to tell us a little bit about their story and about how technology has played into that. Dr. Mordkin, go ahead.
Thank you, Kristen. Let me thank first MedliMed and Green Room for the opportunity to be here today and sort of tell our story and my part of that story, and also to be on a panel with a very interesting and diverse group of individuals in this space. So appreciate the opportunity. As Kristen mentioned, I'm the Chief Medical Officer at Let's Get Checked. And for those that don't know, Let's Get Checked is a company that was founded in Ireland in 2015 with the idea that there is benefit to putting direct access to diagnostics into a consumer or customer's hands. And the idea here was really around trying to remove many of the friction points that any one of us would often encounter when we go through a sort of more traditional healthcare path. So from having to find the right provider, to then scheduling that appointment with the provider, to physically having to go there, to perhaps sitting in a crowded waiting room, delayed to be seen, and then perhaps having to coax a clinician into ordering a test that you as an individual feel might be important from your own knowledge base of what has been going on in your life, whether it be symptoms or family history. And then what happens on the backside of that experience about getting results back? How do you then go back through the process of learning about those results? Where you even go get the testing done, et cetera, et cetera, et cetera. So all of those friction points are probably familiar to absolutely everybody on this call. And so in 2015, Let's Get Checked started as a platform to allow people to have access to home diagnostics. And specifically what we're talking about here is blood testing. Our platform, at least initially, was about doing capillary self-collected blood testing or urine testing, depending on what kind of test was being done. When we started, it was around using partner laboratories to achieve that testing component. But as we scaled throughout Ireland, into the UK, mainland Europe, and then here into the US, we learned pretty quickly that for a variety of reasons, from quality control needs to the ability to be innovative, to the ability to be excellent in terms of customer service, it made more sense for us to actually control that process and to control the lab. And so to that end, we purchased and now run our own labs. We have a lab that's based in Dublin, Ireland. We have a lab that's based in Southern California that services the US market, as well as a lab in the Massachusetts area near Boston. We are, from a mission perspective, our goal is to empower people to live happier, healthier lives, or healthier, happier lives. And we do that again through direct access to diagnostics. But it's not enough just to have diagnostics, in our opinion. You need to wrap that with clinical support, which means access to a clinician, whether that be a nurse practitioner, or a physician, to help support the outcomes from that diagnostic test, and then guide the individual based on results as to where they may go for care. As we've evolved in the process, we've come to realize that many of the things that we can test for actually likely could be candidate for therapeutic intervention. So for pharmacy, for example. And so a few years ago, we actually purchased our own pharmacy as well. And we built our own physician team. And I know we'll hear a little bit later from one of our other panelists around some of the regulatory considerations when you do that. But we have a dedicated, if you will, physician team that works with Let's Get Checked. And so we really are a vertically integrated, holistic program at Let's Get Checked. We have not outsourced really much of anything. We manufacture and assemble all of our own testing kits. We distribute our own testing kits. Again, we own our own labs to run all these tests in our own high complexity CLIA and CAP certified labs. And then our physician team, again, is respondent to Let's Get Checked, and then our own pharmacy when prescription is important. Around all of that, we also have a tremendous tech team. So we build and manage all of our own tech as well to be, of the highest level in terms of HIPAA compliance and all of that from a security perspective. We started as a direct-to-consumer platform, but have very quickly taken this very solid platform and moved it into direct employer space as well, where we've really found a lot of traction. I think that we were in business for as you mentioned, Kristen, for a number of years, and we're building and doing well. But often we would have to explain really who we are and what we do. This idea of we're going to send you a kit, you're going to collect your specimen yourself, you're going to package it up in our kit. It's going to go in a pre-addressed mailer back to our lab. People had a hard time getting their head around that. And then, of course, February of 2020 happened, and COVID became the absolute proof positive that the model not only works, but was necessary. We were perfectly positioned because of our core competencies around lab testing and clinical support to be able to be heavily involved early on in COVID testing. We scaled our lab component quite quickly to meet demand. And at one point, we're processing over 10,000 tests a day. We were one of the first to submit to the FDA for a self-collected lower nasal swab. If you remember the original early days of COVID with the deep throat swab being done in drive-through clinics and all that, we realized that was probably nobody wanted to go do that. So we used our R&D processes with our lab to validate a self-collected lower nasal swab, shepherded that through the FDA quickly for EUA. And I think we're the first or second, I believe second to get EUA for that. So we've controlled that process as well. We have our own team internally that helps with interactions with the FDA. So we've tried to keep it all in our ecosystem. I'm happy to say that at this point, we've got enough experience, breadth, and depth that we certainly have others reaching out to us to potentially utilize portions of our process, whether that be utilizing our lab for their needs potentially, or leveraging our clinical team to support some other program they may be doing, and or our pharmacy. So we have now customers coming in that may want to plug and play in various aspects of that as we also continue on with our own business and our own sales team there. So I know we'll hear more again about that. There are many lessons learned, Kristen, along the way. I would say, certainly one lesson is that when you tend to own it yourself and build it yourself, maybe it doesn't always move quite as fast as you would like. But as one of our senior people in our team always says, it always moves faster than maybe it probably should have anyhow. So, that has been something that sometimes we would love to move to a process or to a program a little quicker if we were just buying that program, whereas we've tended to build it internally. But that has allowed us to really, I think, control quality as we do this and focus our attention so that we're confident when we bring something to market or out to a customer that it is, at least in our mind's eye, what we want them to have and be the best experience and best quality it can be. So I don't know, with that, I'll hand it back and anxious to hear from others.
That's there. I mean, you really are a success story. And I think that's exactly why we wanted you on, because you could tell that story sort of from beginning to end, having built or acquired things yourself and having learned that you can't, or maybe it's not as helpful to the customer or patient to just offer them a test or just offer them a medication. You really have to have the team behind that to do that full circle that you do. And so we are appreciative of that. I think that's a good lesson for those that are on the line.
Yeah, thank you. I mean, it's definitely core to our principle is it's not enough just to deliver somebody a high quality test. I mean, that's almost an expectation. That's an accepted outcome of the interaction. But the key point is certainly from a consumer end, what do I do about that data, right? What do I do about that lab test that I just had done? What do I do about this symptom that I'm experiencing, and what test should I have done? Or where do I go next with this information? And that's where having that clinical support is, I think, crucial. And in many ways, for us anyway, we believe a differentiator, maybe from what others are doing, because we really believe very much in the idea of wrapping that with this clinical support. We've now created some care pathways around our testing to sort of take it to the next level. So I mentioned prescribing. We certainly can prescribe off of certain of our sexually transmitted infection test results, but we're doing that as well in other spaces around cholesterol care, for example, trying to reduce cardiovascular risk long-term, properly selected patient, certainly if they have really abnormal lipid panel testing, we'll put them through best practice guideline standards and risk calculators. And in appropriate cases, we'll offer them statin therapy. We also have our own dietitian on staff where we've created educational pathways about dietary improvement, lifestyle changes around exercise, smoking cessation. And we also have our own pharmacist as well. So while we have our own pharmacy, when a patient receives a medication from us, we have our pharmacist follow up. So they're interacting with the customer again, giving them that support. You understand how to properly take the medication. Here's potential side effects. If you have issues, please let me know. We have async ability for people to communicate back and forth with our physician team, clinical team, but our dietitian, our pharmacist as well.
That's a good point. Synchronous versus asynchronous, as being able to offer both, I think, is important. And during that whole pathway that you described, there were so many regulatory / legal considerations to consider. And I'm sure Dr. Dashow has some thoughts on that.
Yeah, actually, and it's interesting, evolving from a national health system based compensation structure, if it was an Irish company, to coming into the US. One question I have, and it's not necessarily regulatory per se, but it's very important, has to do with how you evolved your revenue model, because when you're dealing with direct to consumer, the key question is it going to be a covered service? And are you going to, and do you have third-party payer relationships that you've now evolved? So I'm just curious, more from the history, which I think is very, is interesting, how that has evolved, or is this more of a fee-for-service model?
So initially, upon launch here, certainly it was fee-for-service model, cash-based model. Although even there, the regulatory components, of course, are tricky, because you've got to consider state-by-state regulations, which do vary state to state, as certainly as you know. And we've got a lot of counsel. We have our own legal team in-house that spends a lot of time around the regulatory components and not only brewing it in-house, but getting a lot of good outside counsel there, and making sure that we can be operational in every state. And this goes for the clinical team, where we have physicians, nurses, nurse practitioners who are licensed in every state, over to our pharmacy, making sure that they're licensed in any states where we're going to dispense, and being certain we're buttoned up there. And on the lab side as well, the lab needs its own set of licensing. We do have relationships as well with some payers. We certainly have contracts with large employer groups, which sort of meld into that as well. And then we're getting into the we've done some Medicare programs, for example, Medicaid programs on a state-by-state basis. And we're also working now with getting some credentialing components done with some of the third-party payers also. But these all take time. You really have to pick them off one at a time in many ways, because each state has its regulations. And again, each aspect of the enterprise has its regulations. So what may be good for the clinical team may not be good for pharmacy, or may not be good for lab. And so you've got to get all of that synced up. So it can be very, very complex. And I think is, in many ways a hurdle for entry for people. I mean, it took us a number of years to do it and to make sure that we were doing it correctly. And I think obviously that's the most important. We want to be really.
I mean, and you're to be commended, because it is a challenge to have to deal with each component with the expansion of the business in not only from one state to the other, but then you've got relationships you've set up where there are referrals. And those referrals may implicate things like Stark, which if you are doing government program reimbursed services, anti-kickback, depending on how you've structured the arrangements, if it's contractors versus employees. So you're right, and it's good, that you have a team who's able to look at this. It's not a discrete process. It's a process that has to take into consideration so many different components in analyzing the legal side. So it's great that you've gotten as far as you have.
And yeah, a great story for us to kick off the session with, because of the breadth that you've and all the things that you had to the challenges you have to overcome and done so well on. So to juxtapose that, let's talk with Sherry McLaughlin. I think you're still on mute, Sherry. So Sherry is an established provider. She's a brilliant physical therapist and movement specialist who has more recently started to foray into the idea of virtual care. And so we want to hear, Sherry, kind of what you do and how virtual care you think can help your patients, and what is your thoughts on the technology behind that?
Okay, thank you, Kristen. I want to thank you and MedliMed and Green Technology for having me on this very distinguished panel. Yeah, I get to follow Dr. Morgan, who's a big fish in a big pond, and I feel like I'm a little fish in a very big pond. But I hope that with the addition of technology to our services, we can be a little fish in a big pond with a really strong motorboat. So we decided we are experts in musculoskeletal wellness and injury prevention. I have over 32 years in background in rehabilitation and physical therapy. So I own a small physical therapy practice here in Southeast Michigan. From all of our work here through the years, we have a real heart on trying to prevent injury. We see a lot of people that come through here that have injuries that could have been prevented months and maybe years before, had they only had proper movement screenings and their asymmetries in movement and posture been corrected. And a lot of that can be done in the corporate sector. So we launched a program called MoveWell, and MoveWell pre-pandemic was delivered on site. It was a series of screenings. Our tagline is nobody has time to be in pain. So we have 1-hour webinar or seminars. We have 5-minute screenings and 15-minute one-on-one consultations. So no matter how much time you had, if you could have contact with a MoveWell movement training specialist, we could help you figure out what's causing your ache and pain and probably prescribe several movement activities that could pretty much eliminate your pain with doing those in just 1 or 2 weeks. The interesting thing is in the corporate sector, musculoskeletal injuries are costing a fortune, and many corporations are going right to medical care for it. And there's many of what we call the walking wounded. So the interesting thing in the space that we play in is that in a corporation, 10% of the population will take part in any wellness program you put out. If a company builds a $15 million gym, 10% of the people will show up and sign up for that. If they do webinars, they'll sign up for that. They'll sign up for every wellness thing. And these are the 10% that are not costing the corporations much money. Then there's about 30 or 40% of them that are high readiness. They know they want to make a change, but they're not sure what to do. That is a rich market for us. And then there's the rest of them, 50% or so, that are very low readiness. They're the ones that are costing the most amount of money. They have no idea what to do, nor are they interested in taking part in anything that looks like something very active or something very exercise-like. And so our focus at MoveWell has been to try to target those folks. And these are the folks that are very leery about going into a gym or signing up for a membership because they don't know what to do, and it's an odd space for them to be in. Pre-pandemic, like I said, we would show up and do seminars and then immediately do movement screenings. Our company, after that, was very low tech. We would deliver services via email. A lot of times we'd have a point person in the corporation that would disseminate information for us. So the corporation would pay us a yearly licensing fee. Then they would have access to all of our informational stuff, articles, webinars that were pre-recorded, exercise programs that we have. for various populations of people. But then we were kind of dependent on them to disseminate the information. If a company had a wellness team, we had a little closer connection with what the problems were on the ground, but they were kind of our team that would listen in on where most of the injuries were occurring. They would give the information to us and we would deliver solutions. But it was pretty much low tech. People were used to seeing us, a team of us, come on site once a month or once a quarter to do screenings and deliver our programming. As we've been in the wellness space since 1998, it was mostly back then, wellness was someone showing up and doing a seminar and then leaving. Obviously, it's evolved since then, and we've seen the market go from kind of a program like ours that's all face-to-face to something go fully virtual, of which we were not able to take advantage of for financial reasons. We're kind of a small fish in a big pond, but there were companies that delivered 100% virtual wellness programming, and it all looked really slick. The really interesting thing was I had several clients come to me and say, do you have something like that? And I say, well, what do you like about that? Well, it looks really slick. And I'd say, well, what don't you like about that? And they said, well, it doesn't really work. So they would have this really slick interface that people could tap into. And they found out that a small percentage of people would tap into it when it first launched. And then after that, they wouldn't tap into it for any more information. This was our proof that the face-to-face contact was definitely an important way to create a relationship. Well, we want to be the people that are known as the information specialist for any ache or pain you might have. You have a pain in your neck or in your knee, and it's not enough to take you to a physician. We want to hear from you so that we can do a quick screening and then deliver a movement program. So we found that, I mean, obviously it's not economical to fly our team all over the country or all over the world. And where we were running into problems was corporations that had 10,000, 20,000 employees and couldn't take on a program that they couldn't deliver company-wide. Then the pandemic hit, and a lot of our clients, it was a little bit slow, but they got very used to seeing our services delivered via webinar instead of live seminar. And then people were really in a lot of pain, especially folks that were relegated to working from home and sitting at a desk for many more hours. We started hearing from them, can we have a virtual visit with you? And we would open up a Zoom room for them, and we would do virtual visits. And so it really forced us to focus on a delivery method that we could do virtually, a series of tests that we could have the person do in front of the camera or answer questions themselves by looking in a mirror, and based on that information, give it back to us, and then we could deliver solutions to them. Even then, we're delivering them via email largely, or we would get back on a Zoom webinar or Zoom meeting, and we would just demonstrate exercises. So when I heard about MedliMed, it was really, really exciting to me because the ability, our needs don't seem, the need to deliver something really effective and efficient in the musculoskeletal wellness space doesn't seem to be too difficult, right? If we have a portal that we can speak to someone via video conference and then take some notes and then immediately upload solutions. A lot of our solutions are in the form of PDF downloads or videos that are, demonstrating certain exercises. So someone could reach out to us, have a little meeting, and then we can upload pertinent things to their folder and have them come back to a similar space to be able to check in and be reviewed on what needs to be done, and then have follow-up visits. That would really open up our ability to impact a greater number of folks, and to be able to provide services for larger corporations. So,
And you say that you were talking about big fish and small fish, and I think you would say that all of your patients, everyone is a big fish, and I think we should think about companies like yours. Even though you think of yourself as small, it still can benefit from it, and your patients can benefit from technology solutions that help you get out there to reach more people. And so I think that's an important point. And it's also important that it doesn't always have to be about prescribing. We always think, because we see these ads on our social media all the time about getting online and getting your asthma medication or your ADHD medication or whatever it is, you're able to prescribe exercise. You are the lab because you're doing the testing as you're watching them on screen, and then or having them fill out some form asynchronously, and then you're prescribing education and exercise, which is just as valid and just as important as in prescribing as actual medications.
Right.
Yeah.
Sherry, did you have any comments on this,
Yeah.
this model?
Actually, I do, Sherry. I'm interested in knowing how the employees get to you. That is, does the employer market you to the employees? Are you part of a benefit to the employees in the arrangements that you set up? And the second question I'll ask is, you were doing this on site. So when you were doing it on site, and even virtually later on, how did you manage or maintain the records, the clinical records? And this, by the way, is also, I think, a question for Dr. Mortkin that I didn't ask, which is who keeps the medical records or the clinical records and who maintains all of that, because those are important components.
Yeah, so we maintain all that ourselves. We have our own HIPAA compliant portal that we've built. We have a customer facing portal so the patients can interact with us either via web-based or they download. We have an Android and iOS app from the App Store they would download that interacts through a HIPAA compliant platform. And then our clinicians work on our own on also HIPAA compliant platform that's facing to our clinicians and then interacts with that consumer facing side. So we have our own EMR that we've essentially built.
Which takes care of a lot of the compliance issues for you. Frank.
Yes.
Yeah.
Yeah.
So Sherry,
because
what
right.
about
Otherwise it's
you?
We're usually brought in by the wellness team. So we're not really brought in as clinicians per se. We're brought in as, it would be as if a company brought in a nutritionist to talk about healthy eating habits.
Okay.
So we come in and we're usually marketed by that wellness team. So we will come in and do a seminar, and then the team member will say, MoveWell will be around or will be available for 15-minute screenings on such date. Sign up for your time. So when we started doing it virtually, it was a virtual sign up. Then we take our information down. We have a database here that's HIPAA compliant here, but that information doesn't go out to anybody. We just use it. We use the aggregate data to report back to the employer. Basically data like the number of people that took part, what's the age demographic of the people that are taking part in these programs, and we use that data just to turn back and recommend future wellness programming.
And that's, by the way, really important, because the last thing you want if you're an employee is for your employer to be having access to all of your private personal information. And there are laws and regulations that say employers.
Exactly. You have to be careful what you're reporting back to them for sure.
Yeah.
So,
Right.
so now we can sort of circle back around. Thank you, Sherry, by the way, very much for that and for your questions, Sherry. Let's circle back around now back to pharmacy and to Dr. Lisa Fast, who is the CEO of Diversify RX and has also recently launched the Pharmacy Badass University, which helps pharmacies figure out new ways to generate revenue and stay connected to their community. Lisa, why don't you tell us about you? You're on the.
Thank you so much for having me. Pharmacy is a big component, obviously, of healthcare. For so long, it was kind of thought of as an outside. And I think one of the benefits or the good outcomes, if you can call that, from COVID is really pharmacists have really been brought into, I think, a forefront of conversation. So when you're talking about delivering healthcare and talking about through technology, I think there's a big opportunity for especially independent pharmacies. Right now, as an independent pharmacy owner, it is not fun. There is lots of things against us. The PBMs, the pharmacy benefit managers, they keep cranking down reimbursements and keep cranking up audits and things like that make it really hard for pharmacies to just survive, not even, make a profit. But, what a lot of people don't realize, even practitioners, other doctors, nurses, and other people in the healthcare world don't understand that for many pharmacies, sometimes 20, sometimes 30% of every prescription they fill at a loss. They lose money. And that is really hard to sustain a business when you're constantly bleeding out cash. And so one of the things that I've been really trying to talk to pharmacy owners about is to leverage technology to deliver healthcare in new ways. And it can get kind of tough to think outside of that box because pharmacy has been such a physical health practitioner. We've never been able to have a consult by a phone and dispense the medication because you can't dispense the medication over the phone. And so we've always felt felt very physically tied to the prescriptions. But I think as what COVID has taught us is that there is a lot of care that can happen via digital means, and even more care when you layer that on top of some physical in-person, whether that's delivering the prescriptions and then having consults digitally. But I think pharmacists are in a great position to help the communities, and really with technology, it can be entire countries. You really get to break out of that mold of that 5-mile radius, around your business by helping them with. We've talked about wellness, we talked about nutrition, we've talked about all these different things. I'm a big fan of Let's Get Checked, and having pharmacists integrate lab testing and things like that into wellness, because the practice of pharmacy, which is regulated by the state boards of pharmacy, is obviously very, very rigid within the state guidelines. There's obviously lots of rules to follow there. But when you get into the wellness space where you're dispensing just wellness advice and trying to help people live healthier, happier lives, you're not limited by those same restrictions. And so a pharmacist can hold a weight loss class, and they can invite people from all over. It doesn't just have to be their little community, doesn't even have to be their city or their state. It can really invite people from all over. And now pharmacists can monetize that knowledge that they have that goes far beyond just their boundaries and really gets to broaden their horizons. And so I think leveraging technology for these types of things, pharmacists are just perfect. We're kind of jack of all trades because of our education. We obviously get more drug education than anybody out there, but I think a lot of people forget that pharmacists, they have a doctorate of pharmacy degree, and they have lots of years of lots of other medical-based training. And then we all have our own specialties. A lot of pharmacists are into functional, they might be into diabetes care, but there's a lot of like little niches within pharmacy that I think leveraging technology allows each of those individual pharmacists to really flourish and provide the good patient care. But now we get to do it kind of without borders. Like we actually get to service patients that want our service, because in the traditional model of pharmacy, we can't just service the patient. We have to wait for a doctor to make an order. We have to wait for an insurance to pay it, and then finally we get to deliver our service. But when you kind of step outside of that dispensing box and into just patient care, patient education, and you get into wellness and functional medicine, now you actually really get to market yourself. You get to sell your services, and you get to service your patients in a completely different way than just the traditional pharmacy model, which is very tied to a location, a physicality, and a closeness for optimal patient care.
Yeah, that makes a lot of sense. I think there's a lot of ways for pharmacists to expand, even back to the more traditional prescription way. How many times do you come out of the doctor and because of what's going on with you, you're not thinking all that clearly, and you go pick up and it's really your pharmacist that talks to you a lot about about what's happening, and to be able to have a virtual visit later on with them, maybe, and ask them more questions about your prescription would be very helpful as well. I think it's a great opening and a great way to stay connected to the community.
Yeah, absolutely. That's the thing, is information we've just got so used to being in person, pre-pandemic, that it wasn't just in our thinking. But yeah, you're absolutely right. Patients get overwhelmed. I mean, you go to the doctor, even if you go to the pharmacist, the pharmacy provides a consult, you might have just got a major diagnosis. You just had 1,000 things thrown at you. I think what we're understanding now is patients really don't get it the first time. We as humans don't get it the first time. We need repetition over and over. And I think that's where these like group classes, if you can imagine a diabetes class for newly diagnosed diabetics, and being handheld on a weekly basis by a pharmacist for maybe 4 to 6 weeks to really like let that diagnosis sink in and let that journey really begin in a very calm and not overwhelming manner, how awesome are those patients going to now understand their disease instead of just one pill in the morning, one pill at night, and just, check box, do these things. I think that really is what's lending to patient care. And I think the more that the healthcare team leverages pharmacists, I think the better off we all are. I coined a phrase in pharmacy many years ago to work at the top of your license. And I think just as the healthcare team, I think that's what we all want to do. I mean, there's certainly things that are only within the doctor's scope that they need to be working on. And if there's something in a nurse's scope or a pharmacist scope or a nutritionist scope, like delegate that out to the lower end providers so that they can keep doing the maximum care that they can. And if we all work together as the healthcare team, with everybody working at the top of their license, really the beneficiary is the patients, and they're going to get better care because they're going to have better access. I think that's really what it comes down to, and it's just better access to care. I mean, that's what Let's Get Checked is doing with, testing at home and getting your own results, kind of be in charge of your own health again. I was actually just talking about this with my sister-in-law, and it was like, she had to go through 10 hoops to figure out what her results were from her doctor's office for her recent labs. And it was such a frustrating experience. It's like, why can't it just be, they're my labs? Like, why can't I just have access to them? And I think that's a big thing, a big component of healthcare is people feeling in charge of their healthcare and having access. So.
Agreed. When while the regulations are opening that up for the world, that patients are supposed to be able to get their information, they might not understand it. So being able to come back on virtually and talk to somebody, especially somebody in their community, I think is awesome. And so Sherry Dasko, what do you think about the regulatory aspects of adding virtual care from a pharmacist perspective?
Oh, I think that it makes a lot of sense. I think pharmacists, like labs, were very early adopters of virtual care, but pharmacies have as well. I mean, they have been also at the forefront. I had one thought that came to me, Lisa, while you were talking, and it just made me think of something that makes sense when you talked about working to the top of your license and creating these relationships. I think what you're talking about is, first of all, you've got to identify scope of practice and what can and can't be done by whom, and whether or not there are opportunities to leverage different providers together with the pharmacist to create more integrated structures so that, and again, I think this is what's been done already in Dr. Mortkin's organization, but you have that opportunity. I also know of of pharmacies that where labs do this, but they interact with each other in such a way that if I don't have that particular medication, I have a relationship with another lab. We are able to coordinate our services to the patient. And then last, having been very much involved in the early on-site clinics movement, I was very much involved in that when it first evolved. There are opportunities to move in that direction and take advantage of, even on a virtual basis, even. And again, Dr. Mortkin, I think your organization seems to have built on this ability to integrate, starting in one place and then evolving to others. And the ability to create the affiliations and the relationships is very important. From a legal perspective, again, it's going to come down to who's doing what are they able to do, what is delivery of healthcare versus what is accommodation, or the types of things that you were talking about, inviting a nutritionist to come and meet with a group of patients. I think the key question is going to be, what's the revenue? What's the return on investment for that type of activity? So I guess one way is you do it to build volume for use of your facility, or you do it and charge a nominal amount to cover the cost of the nutritionist or whomever you're bringing to talk to your diabetic patients. But you still have all of the regulatory issues that any provider has. You have to maintain compliance with all of the patient privacy requirements. You have additional responsibilities because of the oversight of pharmacies in general. And of course, in what all of you do, you have liability exposure if there are errors or mistakes made. And when you work in a system that you control, or you make an integrated system, you own it. So if one person screws up, it can have ramifications across the entire network.
Great.
Yes, very, very well put. And you're spot on about the scope of practice. I mean, when it comes to scope of practice for pharmacists, there's like no two states that are alike. The map looks completely like a rainbow out there. There's really no consistency. Obviously that's one of the things that we're fighting for as pharmacists, but
Right.
yeah, you're absolutely right. And I think integration with other healthcare professionals is just key to great outcomes. It's just key to great patient outcomes. I mean, that's, you know, there's been study after study after, study done that, you know, when a whole bunch of healthcare practitioners with different specialties get together, you know, patient outcomes improve. And so I think that sometimes pharmacists are forgotten about a bit, but whether it's PGX or, allergies or nutrition or weight loss, like all of those things have an effect on the medications that the patient is taking. And, go ahead and, talk to your local pharmacist. If you're a doctor listening to this, you probably have a local independent pharmacy that is more than willing to work with you on probably just about anything you propose to them.
And what you raise is really important because I think that many pharmacists, particularly those who have not been entrepreneurs or business savvy, they kind of work in a silo. They believe this is what I do. When you look at clinics, particularly even federally qualified health centers, many of them cannot have they're just not set up to have their own pharmacy on site, but they have the benefit of 340B drug program, and therefore they could have a relationship with a pharmacy and drive volume to that pharmacy. And it can be done virtually as well. And so those are arrangements that I have seen set up. I have set them up. Similarly, being able to physicians who sometimes want to have a way to access or dispense medications in their own practices who need a pharmacist. I mean, there are some things they can do, but it's very limited. So being able to have a relationship with a pharmacist is also very important. So if you're looking at how do you expand the picture and expand the opportunity, it's breaking down the walls and being able to look at it a little outside the box. Yep. And still respect the fact that you still have to pay attention to the regulations, but you can do that.
Right.
And I think Dr. Bordkin, again, your story tells a good one, because what you guys have done is you've incrementally grown and you've added your services in a strategic and thoughtful way.
Thank you, Lisa. We appreciate that. And if any pharmacists are online, they can come to you if they have questions about how to get started in their own state. And
absolutely, yes.
Then let's go ahead and just switch over to Dr. Dashow again. And just so you want to just kind of sum up we looked across a broad spectrum of types of consumer care, from direct to consumer, direct to patient, direct to employer, and pharmacy provided. Right. Can you kind of give us your overview on where you think it is?
Well, let me take a couple of steps back and let the people listening know that I have been spending many, many years working exclusively in healthcare law. I'm a board certified attorney. I practice in Texas, California, and elsewhere, with a pretty deep bench in regulatory compliance and structuring transactions. And what I see with all of this are several factors, and I think some of them you've all brought them up. Number one, it's in my little blurb here, but this is a highly regulated industry. And it was already regulated before you introduced the direct-to-consumer component. And the direct-to-consumer component has added additional regulations that are imposed on the way in which healthcare is delivered. I grew up in a small town. My father was a general practitioner, and patients came to him, and it was all fee for service, and it was all hands-on. And he did the work. It was a piecework. He did the work. He took care of the patient. He billed the services, and he got paid. And it was just him. But now the healthcare industry has grown. The pandemic has really significantly affected how care is provided. What the pandemic did is it relaxed a number of the regulations that everyone worries about when they engage in the healthcare industry. It relaxed issues such as antitrust. It relaxed the issues on Stark and anti-kickback. It relaxed telehealth, and telehealth in particular also opened up a lot of the opportunities for other forms of virtual care. And the direct care component has come on board. But the fact is, the regulatory issues don't go away; they just become compounded. And so, when you are involved with the direct-to-consumer transaction, and each of you really have reflected different perspectives, but also from where you are in your own practices or in your own businesses, that are extremely important. And I hope the people who are listening can understand the distinctions. What has been added to the traditional delivery of healthcare is that we now have, with virtual care, different agencies that are playing in the space. The Federal Trade Commission, they regulate consumers and competition. They're concerned about deceptive and unfair practices. So all of a sudden, there's a new layer of exposure that may be different from the traditional liability, med-mal and other liability issues that previously existed just with a direct patient care. Recognizing that, I think when Kristen and I first talked, I tried to make a distinction between the three categories that she had identified and tried to identify as part of this program. The first is the direct-to-consumer. Now, the way I look at a direct-to-consumer, in one sense, is that this is somewhat of, there's no relationship developed. So when you watch TV and you see the ads for Trulicity or any of these other pharmaceutical products, that is the pharmaceutical company advertising directly to the consumer base. They're not driving it. What they're doing is they're empowering the consumer. They're saying to the consumer, you really want this. And yes, it may be very expensive, but you should go ask your doctor if it's good for you. And that is a form of direct-to-consumer advertising. And the advertising itself is subject to very detailed, far beyond what we have time to talk about, regulations that can be imposed and have serious consequences if you're not paying close attention. But then you have the direct-to-patient interactions. Now, all of a sudden, you have brought a relationship into the picture. And with that relationship comes a number of other factors that I've touched on as I've asked my questions and raised some of the issues, which is all of a sudden you are engaged in a relationship. That person is looking to you for ongoing care, or at least they're seeking care from that organization. And there's an obligation or duty on that organization or individual's part to address the concerns of the patient. When you get into direct to employer arrangements, those are oftentimes in the interest is on the part of the employer, who wants to be able to take advantage of lowering costs, addressing needs, particularly for employees who need access. I have set up many employer-based clinics, and many of these clinics have gone virtual as well. And that is another opportunity for those who are looking to expand and enter the virtual market. But employers are very concerned about cost, particularly if they're self-funded employers, and because they bear the brunt of the expense for the services. And so when you look at these three components and you kind of segregate them, each of them comes with their own set of regulatory issues. But I actually have kind of a list of questions that I would be asking, or I would say you should be asking when you are thinking of getting into this space. Okay.
That's perfect, because we actually just got that question. So thank you.
Oh, good. Okay.
Nice timing.
And I welcome all of you to please jump in and comment, because you're dealing with these issues as well. First of all, the first question I ask is, does it involve direct interaction with the health service providers? That is it a distributor of a product, but is it a direct relationship, or is it what I call an indirect or direct to consumer interaction that is without creating, it's just marketing, pure marketing. And the second question is, what is being marketed or sold? Because the type of product or service being marketed or sold is also going to be subject to its own scope of regulations and considerations. Is it a licensed practice? Is it just wellness? I have found working with my clients that there is this fine line between the healthcare, which might be a regulated activity, and well-being and wellness, which is technically not a fully regulated activity, although many states and many of these organizations like the Federal Trade Commission and others are looking into these because there is no one really looking at the interest, the consumer and the protection of the consumer. How do you market it? How do you market the services or products? That is a really key issue from a regulatory standpoint, because aside from the Federal Trade Commission, depending on what your product is, you've got the FCC, Federal Communications Commission, and that introduces potential how you're communicating and who you're communicating with. And believe it or not, there are regulations that make certain types of communications or unwanted communications illegal. And you have to create, it's like they call it the NOBO robo or the do not call lists. But when you have those kinds of marketing activities, you've got to be very careful, because there are regulatory schemes that can result in fines. Obviously, the Food and Drug Administration is in the mix as well. Another question. Does the interaction seek to establish a regular and direct relationship with the individual customer? It's a little bit the same as my first question, but sometimes these arrangements start with something that's a bit more distanced, but the people eventually come to look at that organization as their provider. And where do you draw the line in the relationship? And at what point does the entity that's providing or interacting with the consumer step into being a provider of services? And is that a role that they're prepared to take because of what comes with it? Do you give the recipients the opportunity to opt out? If you are doing marketing and you're doing, there are all these people who sell lists. They sell lists of people. And when people often start doing marketing, they will go out and they'll send out these anonymous communications to as many people as they can. You've got to give them the right to opt out in those circumstances. And I think that this has already been addressed, I think, as part of Dr. Mortkin's discussions. But you need to, when you're establishing these arrangements, there has to be both disclosure and disclaimers. That is, you want to be sure that you have documented and identified in advance what the role is, what the responsibilities are, and those become very important compliance tools as well as limiting liability situations. So, I mean, those are really the high level items, but there are a number of do's and don'ts that go with this, but maybe what we should do is give the audience an opportunity to ask their questions.
Yeah, and that was a question, so that was great. And there was a follow-on to that, which I think will give us just enough time to kind of wrap it up, which basically you touched on all the components. But so what if I am new? The one question was, what questions should I be asking? What should I be thinking about? The other one was, should I build versus buy? And what do I need to think about on those terms? And what do I need to think about in the vendors that I'm looking at? And I think you really hit on that when you started with the engaging the customer. So what are you selling to who and how and why, right? And so how do you engage? Does the platform that you're looking at help you engage the customers? And are they aware of all those legal and regulatory things you just mentioned? And then once they're engaged, usually there's some kind of initial qualifying quiz that starts the PHI, starts gathering personal health information from the patient. Where does that live? How does that transition occur? where's that stored?
Right.
And then from moving into there, does it allow you to, if it is a prescription based thing, does it take into account all the state regulations and all the other things that are involved there? But then if you're not, if you're like Sherry McLaughlin, does it allow you to prescribe things other than medication? Can I prescribe education? Can I prescribe movement training? Is there other kinds of things that I can, because there are many interventions that are not just prescriptions, right?
Well, I will say one thing. When I hear the word prescription, I'm hearing a medical encounter.
Mhm.
So prescriptions by themselves are a directive to justify reimbursement or coverage. So, and that's where a lot of people try to differentiate their products and programs is I'm actually offering something that is, and most of the time it's going to end up being a fee for service, unless it is connected either with another existing integrated program,
Mhm.
or it's associated with an employer that wants to be able to offer those services as value added to their employees.
But yeah, that's a great distinction. And we're just about out of time, but I want to thank all of our speakers today. I think this is a really good breadth across the field and with some really good input and interaction between you. So thank you to all of you. As the people who are watching today, you're going to get a follow-up email that will include the ability to, if you'd like to learn more about MedliMed, get a demo or potentially speak to one of our speakers or one of us. So there'll be a form for you to fill out to get that information, as well as see the video from the whole speech today. So thank you to everybody on behalf of Green Room, MedliMed, as well as all of our speakers. We appreciate your time and look forward to interacting more with you. Thank you, everybody.
Thank you.
Thank you.
Bye, everyone.